Hi, I'm Adam Balin. I'm really honored to be here speaking with you today. I'm a family physician. I've served in many roles in my years at Dean Clinic. Currently, I'm a primary care regional medical director in addition to my clinical practice. My practice is in a small town just south of Madison, Wisconsin. Before I go on with my presentation, I just have to do 2 shout-outs. I want to thank the choir because they put me at ease to do this, and I am awake. I also want to do a shout out to the karaoke crew that came from Wisconsin that most of you don't know about. They displayed their talents last evening. It was inspiring. And lastly, I want to express my appreciation for the fact this is being filmed because I can prove to my daughter, my fashion advisor, that I did wear the tie. I'm not usually a tie guy. I also want to tell you that in spite of what you heard yesterday about docs not liking the EMR, I'm actually a fan of Epic, and since they offered my daughter a job, I want to do the Happy Dad dance, but they've risen in my esteem even further, so has the EMR. But seriously, why I'm here today. Just recently, I was communicating by my chart with a woman who's been my patient for over 15 years. We've taught each other a lot over time. One interesting thing I learned from her is that there is a condition called fetal methotrexate syndrome. It's why her limbs are misshapen and she's missing many of the digits on her hands and feet. She learned about this diagnosis as an adult who had never been told when she was growing up why she looked different. What she and I deduced was that her mom had tried to abort her pregnancy unsuccessfully by taking methotrexate in the first trimester. She subsequently inquired of her dad about this, and she got some sketchy details. Her mom is deceased. But what she found out seemed consistent with that explanation. Now, obviously, there's nothing we can do about this now, but it felt good to her to finally know, even if that knowledge brought some pain, too. I'm mentioning this patient because she exemplifies many aspects of what I want to talk to you about today. First, she reminds me of something that I think about every single day, something I was taught by one of my professors in medical school, just down the interstate, actually, at UMC. Dr. Mauch taught us that every patient interaction is a gift, something bestowed upon us by our patients. They trust and value our opinions. They confide in us about things that no one else is ever going to hear or know. And by doing so, they confer sacred obligation upon us. They also allow us to give, to serve, to learn, and to know part of our own purpose. And this is the gift. From each patient we care for, there's something to get, to understand about ourselves, about the human condition, about life and all it entails. It's not about money or power or prestige. It's about caring and compassion and respect for others. And that's something that we may have to remind our peers and fellow team members about from time to time. Because sometimes we in medical care become distracted by all there is to do, or by the stress we feel, or the uncertainty. This can even lead to cynicism. As leaders, we need to help our teams to remember the gifts and what our work is really all about. I also mention this patient because since they moved to Florida a few years ago, she and her husband still fly back twice a year for their care in our clinic. Now, these are not very wealthy people, and I find this fascinating, but it's not rare in my experience. People who move away to retire or who get a job elsewhere often find that their health care there is not what they were used to at Dean. Why is that? What are we providing that they're willing to cross the country to come back to get from us? I'm quite sure that the magazines in our waiting rooms are not that interesting. I've asked some of these patients, and my conclusion is that we're doing some things differently from how medical care is often delivered in other places. For one thing, we're very aware of the context in which we exist. Change is happening in healthcare in our country, seemingly too rapidly for the comfort of some. Others say, hey, we have the best healthcare in the world, why mess with it? In fact, we have the most expensive healthcare in the world, double the cost per person of any other country on the planet, and demonstrably not the best in outcomes. The World Health Report in 2000 ranked US healthcare 37th in the world. Big economic shifts are occurring in healthcare, and we're struggling to get our costs lower while at the same time getting the outcomes for our patients better. We are committed to achieving this continually over time. This is the value proposition we often refer to. I've heard Bill Thompson say in Madison, and presumably elsewhere in the SSM system, that part of the SSM strategy in the merger with Dean is a commitment to reorienting to disease prevention, to keeping people out of the hospital, to disease management and population health management, and thereby to improving the health of the millions of people that we care for. Zeke Emanuel, a noted author, physician, and commentator on what's good and not so good about US healthcare, recently came to Dean to interview a bunch of us and to try to better understand what we do and how we do it. I think he appreciated a few of these things, and I'll share some of them with you. We try to remain highly coordinated in the care that we deliver. Our expectations for what the patient experience will be throughout our care continuum is apparently unusual. At Dean, the patient is the center of our focus. I can tell you that when a group of doctors or other staff are having a heated discussion about any topic, even compensation, bringing the discussion back to a patient-centric point of view always helps get to consensus. We know it's the right perspective. It's part of our culture. For as long as I've been at Dean, I've been impressed and proud that that's how we operate. We also pair clinicians with administrators at nearly all levels of management of the organization, from the clinical site team to the medical director, regional administrator level. That dyad structure is essential to making good management decisions and to prioritizing resources for getting things done that are patient-oriented and that improve the value of the care we deliver. It's a system of checks and balances in place at the level where decisions are made that ensures we can rapidly take into account the clinical, the operational, and the financial impacts of the things we do to improve patient care. We also measure ourselves a lot. We believe what Deming said, that if you don't measure it, you can't improve it. Doctors in particular tend to be data-driven, so creating credible data that we then share openly with each other really helps to quickly identify best practices and to assess the effects of changes we pilot or initiate. Not every part of the organization is equally transparent with all this data, but we're getting there. It certainly takes building trust to do this, and the clear message at all times is that every practice, every provider, and every team can improve towards best practice metrics. In fact, we assume that suboptimal outcomes are due to system design and workflow defects, not provider or individual team member defects. So we're constantly looking at our processes and tweaking them to get to our goals. Lastly, we really do collaborate. The Dean culture I've known for 25 years that I've been here is to partner and to share information on the path to improving ourselves. It's what we do at our meetings, and it's how we conduct business with our competitors. We know from experience, our own and that of other top-performing organizations, that we must eliminate unnecessary variation and strive to standardize the processes that yield the best outcomes. A bunch of docs who practice independently and just share space is not a highly functioning team, and it won't yield the best outcomes for the most patients. Our patients from out of state who still come to see us in Wisconsin clearly perceive the difference in how it feels to be a patient in a truly integrated system when they experience something other than that. Now, you and I know that we still have a long way to go to achieve all our goals for our patients and for our healthcare system. I, for one, am certainly looking forward to what our future holds and to the adventure of getting us there. I look forward to sharing and learning more about how we're going to do that at this conference and beyond, and I hope you are as well. Thank you.